I've been asked to give 3 talks for you in this meeting, and this is the one that has the most dense amount of material into it, and I think the one that I have with the shortest amount of time. So I'm going to run through it relatively quickly. I am an interventional radiologist and a biomedical engineer, and I've done a fair amount of work in dialysis. These are my disclosures. I sit on several advisory boards, mostly related to my research in cancer, but we also have relationships with GE and Siemens at the Cleveland Clinic, so I sit on their advisory boards as well. So when I was asked to talk about intravascular ultrasound and dialysis access intervention, I went to our software and searched our reports and found one example of an intravascular ultrasound case. So here it is. This is a fistulogram that one of my partners did about 6 months ago. There were high venous pressures. There was also arm swelling and head swelling and increased headaches. And you can see the stenosis in the axis right about here. Your pretty typical stenosis. Went ahead and did the evaluation, found it, and this is the landmark, angioplasty it, and got a pretty good result. So better access for the thrill, but what about the head swelling, the head and neck swelling, the patient's headaches? And it's very important to consider the patient and the whole patient, not just what's going on in the arm. So this is a central venogram that you can see, and this particular vein here, the hemiazagus, is something you're not supposed to see. So it's suggestive of something that's going on in the central circulation, even though you see a very nice venogram here. Not best quality, but the question is what's going on here, and why do you have this central vein here that you shouldn't have. And if you look at the more detailed venogram, you've got this stenosis there, and this was one of those things that we try not to treat central stenoses unless there's a real problem going on there. And now we've got a clinical problem. Let's make sure this is actually the issue here. You can do pressures across the stenosis, but this was the way we chose to address this was with an intravascular ultrasound. And you can see here that you basically pull the ultrasound probe back through the stenosis, and you'll see the variations from the atrium to the SVC and back in, and there's your stenosis, where you have your really tight narrowing. And you get an image that sort of looks like this. You really have to correlate your ultrasound image with your venographic image to make sure that the area of the stenosis is correlated with the area of the stenosis on the IVUS. And it helps you correlate what's going on in this patient. This particular patient underwent angioplasty, and let's see, I think one of these may be a vein. Nope, well, here it is. So one underwent angioplasty, and we were able to dilate up this stenosis there, and you can sort of see where the waist is in this balloon, suggesting that was a pretty tight stenosis with a lot of fibrous material there. It was angioplastied. You get that kind of a result, and then this is what we see afterwards. We've got this is also a video, if I'm not mistaken. So this is the video before, so pulling back through, and you've got this stenosis. This is after the angioplasty. So remember how tight that was right around the probe, and now you've got this sort of stenosis here. The crack in the intima, you'll get healing and remodeling around this. It will have luminal dilation over the course of the next several weeks, and you'll get increased flow. This particular patient went on to have a significant improvement in head and neck swelling over the course of the next 12 hours and reported no symptoms of headache afterwards. So what are some of the alternative strategies? And I'm going to talk about alternative strategies to IVUS, which digresses a little bit from the topic that I was asked. But as I went through this and I was thinking about, what is it that you really want to know and what is it that you want to think about, we definitely have the ability to do flow measurements in dialysis access with intravascular flow meters. You can also do flow measurements with ultrasound, as we just heard described. And then I'm going to talk briefly about DSA calculations, because that was a paper that was just published by my PhD student, and it was the topic of his PhD thesis, and I'll tell you where the errors and problems with that are. The other thing I would talk about is pullback pressures and pressure measurements going all the way back 20 years when I was a resident, the Sullivan's criteria, venous pressure in the limb of a graft. And then physical exam is very important. As an interventional radiologist, I will tell this group of auspicious nephrologists that I teach physical exam to nephrology fellows every single year. And I think physical exam is still an important part of what the physician should be giving to all of the patients. So all of what we're talking about is great, and it's an augment, but remember, it's the history and physical exam that will get 70 to 80% of all of the identified problems. So this is an example which illustrates several of these issues. This was a graft that I did last week. And so we got in and did a fistula. This is the loop graft, this is the stenosis, this is the outflow vein, and this is the systolic blood pressure of 96/50 with a venous limb pressure of 80/45, which is significantly elevated. Sullivan's criteria, the venous limb of a dialysis graft should be 1/3 of systolic pressure. So you have a stenosis here, and you see the drop in pressures as you go. So this is another indication of the location of the stenosis. It's a tool that you can use. This was after the angioplasty, got it down to 55, didn't really like that very much, so I did a cutting balloon on this and got it down to 43, which was okay, but the physical exam at this point was excellent and much better than at the beginning of the examination. And I would say that if you're going to do a physical exam in the midst of an intervention, you should learn to palpate the thrill. And the thrill should be felt with the thick part of the palm of your hand. That's where you'll detect the vibrations best. You'll feel more pulsations on the tips of your fingers. And you should feel the thrill throughout the entirety of the axis, and that's what was present here. So to confirm, I put a catheter in, and this is a thermodilution catheter made by Transonics. We have them in our department. There are very few departments that keep this in the United States because it's an extra cost to keep it and there's no reimbursement for it. But in situations like this, when you can measure the flow rate and the flow rate is 1685, this is not a fistula that I want to do any more interventions on right now. So those are a couple of the exams, and this is the central circulation because I can't show a fistulogram without showing the whole fistula. This is the paper that Dr. Kerala, my PhD student, published. This was the clinical piece of his PhD thesis. And what he had done is over about 2.5 to 3 years done a lot of bench testing to look at, is it possible to quantify actual flow rate from a DSA? Because the concept here is that if you can automatically outline the outside of the vessel and then measure the distance and the peak intensity of contrast enhancement, you could, in theory, just use your diameter and flow calculations to calculate your bulk flow. This is not a new concept. This is something that's been around for 15 or 20 years, but the error here is extraordinarily high. In previous literature, it's like 80-85% flow rate errors. And so the question I asked him if he was going to do a PhD on this is figure out how you can reduce that error to something that might be more meaningful. And this was the clinical study in 22 patients. And in these bifurcations, he would sort of pick a spot, the catheter tips down here, where he can get laminar flow in the outflow where it's more consistent. This is what his results were. These are DSAs, 3 and 6 frames per second, and then pulsations on fluoro. And the best results were really the 6 frames per second with a standardized injection. And you still have a 20% error here. So the idea is that we was able to reduce the error by about 60%, from about 80% to 20%. If you have a significantly high flow, 1,000 cc's per second, and you get it out of this, it's probably fine. But if you have anything close to 600, you probably have to do something else. But this is, latest data needs more improvement. So what is the data on IVUS? Okay, so this is this is a good review that I found that summarized it. And in the central veins, there's not a whole hell of a lot of data. Okay, you've got 2 case reports with 1 patient in each of them, and this group of 12 patients who had residual stenosis identified with IVUS. And the concept is that they were able to identify the stenosis with IVUS. In these 2 patients, it was patients who were allergic to contrast in the first place. Just remember, not all central stenoses should be treated. This is just the ability to treat them, so use your clinical judgment on when you're going to treat these patients in the first place. Of more importance is this paper by John Ross, which came out in 2017, which is a prospective randomized study of patients who had intravascular ultrasound in the guidance of their peripheral interventions in the access. Okay, so here's the way this is. This is an AV graft patients. They had angiography plus IVUS in 50 patients, and they just had angiography in the other 50 patients. And then they looked at the characteristics of the index procedure to decide whether the IVUS would have made a difference in decision making. And then they also did a 3-month and a 6-month follow-up to look at reinterventions or the discontinuation of use of that access. So he was looking at the influence of this IVUS on whether it would change what happens to the outcomes of the interventions. And the thing about Ross's practice in South Carolina, this is an outpatient dialysis access intervention center, which is multidisciplinary, includes interventional radiologists, vascular surgeons, and nephrologists all working together on the management of patients with dialysis access, and it is exclusively a dialysis access center. So it's a very large volume of patients that come through that place, and they're able to do single center studies like this. The demographics were essentially the same in all of these patients, and the number of years on dialysis, about 6 years. The access characteristics, again, are essentially the same. There were double the number of HERO catheters in the DSA plus IVUS group than there were in the DSA group, though, and that was something that was commented on in the paper as well. And these were his outcomes, which were quite interesting and sort of showed that there's some signal here. He noticed that in the patients who did not get IVUS, the early failure rate was much higher. So the idea being that with IVUS, you were going to detect subtle lesions that you might not otherwise detect on the DSA, that you would just go untreated. And if you treated those, you might be able to push that time with which you're going to have a failure to later. The overall outcomes were not statistically significant in this patient population, but he was able to do a sample size calculation on the basis of this pilot data that the 150 subjects should be able to be randomized appropriately to look at for this kind of a difference. So this suggests that further evaluation of the use of IVUS in peripheral intervention may be, meaning non-central vein stenosis, may be of some benefit to improving the outcomes of patients here. And then the last thing I wanted to show you was this, because it's interesting, cool, and relates to sort of the biomedical engineering side of my psyche. This was a semi-quantitative analysis of virtual histology from IVUS. And this is an example of what these virtual histologies look like. So Volcano, and I will disclose here, my chairman of BME was the guy that invented this, Jeff Vince. So this is the way the system generates these images, and it's based upon the different acoustic energy as it passes through the different pieces of the neointimal hyperplasia in the wall. And this particular research group has done a lot of work with vitamin D and vitamin D receptors in vascular access stenoses, and identified that a high density of vitamin D receptors can be associated with a particularly resistant venous stenosis. And so they were looking to see if intravascular ultrasound using virtual histology could predict very, very fibrotic lesions. So they had 10 patients who had IVUS-guided PTAs over this 13-year period of time. The average age was 75. They had 11.5 years of follow-up on these patients, and these patients were undergoing between 4 and 8 IVUS-guided angioplasties per year. So these were all highly resistant IVUS stenoses. 3 of these patients ultimately went on to a surgical revision, and the stenotic lesion was excised and looked and examined for the vitamin D receptors. And this is an example from their paper that sort of shows what happens. You have this really tight stenosis, and then you angioplasty it, and you get the intimal crack and the dilation. And the virtual histology can look at this area of stenosis after angioplasty and look at the increased density of this fibrous tissue in the plaque. And as the vein dilates, you still have this area of fibrous density within the wall of the vessel. So, and again, my caveat to this is a mathematical algorithm based upon the data that is present in ultrasound. We've talked a lot about ultrasound today, and I'll point out to you that the data that you actually see on the screen in ultrasound represents 2% of the data acquired by the machine, okay? It's that other 98% that includes additional information. This is the histological correlation that he has here. This is the IVUS. This is the same area. You can sort of see what this looks like. And then these are his staining for vitamin D receptors. Very high density of vitamin D receptors in the cells involved in this area of neointimal hyperplasia. So from an assessment of the vascular biology of what's going on in the stenosis, this particular tool of virtual histology on the intravascular ultrasound can be a very powerful scientific tool that'll get you much better information about what's going on biologically and allow you to follow patients longitudinally that you can then correlate to what histology should look like. So in summary, intravascular ultrasound can be an extremely useful tool to identify stenoses that need treatment. There is early data to suggest that it may identify lesions in access that, if treated, can prolong the time to the next intervention. That's the Ross data. And that a prospective randomized trial in this area is really what's needed. The last thing I throw in there is that virtual histology can be used as a tool for scientific inquiry, and that the alternates and adjuncts to this include some of the monitoring pre and post procedure and some of the access flow data. I don't abandon what you already know how to do. Use this kind of technology as an augment to it. And that will improve flow for everyone.